Hello guys, we'll start discussing the first question in the INACET May 2025 as per pharmacology is concerned. Okay, we'll look into the first question guys. Which of the following statements regarding thalidomide is correct? First option, used as an anti-metabolite immunosuppressant, used in treatment of multiple myeloma, used in management of erythema nodosum leprosum, and it is teratogenic in nature. Of course, we know it is teratogenic in nature. This statement is a true statement. Why? Because, of course, seal-like limbs, phocomelia can be expected when thalidomide is administered during pregnancy. This statement is true. Most of you would also know that option C is also a true statement. It is used in management of erythema nodosum leprosum. Also, we can use clofazimine. So please note that mild erythema nodosum leprosum or mild lepra reaction can be treated with NSAIDs. If it is severe, we can opt for steroids. In case if the patient is not responding to steroids, we can add certain other drugs like thalidomide or clofazimine. It is used in treatment of multiple myeloma. This is the true statement, guys, because thalidomide per se, if we are not using it, we have a derivative agent from thalidomide named as lenalidomide, which is currently being used for multiple myeloma. Of course, thalidomide is also approved for multiple myeloma because lenalidomide is a PYQ based on INACET. They've asked about what exactly was the mechanism of action of lenalidomide. The same concept we're going to be applying it here. Thalidomide is this also was true statement. Option A also is actually a true statement if it contains only immunosuppressant in it. Because yes, thalidomide is an immunomodulator agent, but it is not an anti-metabolite immunomodulator agent. It is a cytotoxic immunomodulator agent. That's the reason why this statement we can call it as false statement. So correct statements includes option B, option C, and option D. Of course, in your exams, there were multiple options like A, B, C, B, C, D, D, C, A, all these things were given. I'm not going to be confusing you with that. I'll just look into the proper usage of this recall. The answer for this question is B, C, or D. Again, I'm not going into the details about whether all of the statements, question is actually all of the statements are true except or false except. So I will just explaining about what are the correct options, correct things which is pertaining to the question which is given. Good. Moving on to the next question. Which of the following is the treatment for complicated gonorrhea due to penicillin resistant Neisseria gonorrhea? Very much direct question. Most of you would be knowing it because currently we don't use penicillin on the other case because the answer for Neisseria gonorrhea is ceftriaxone. That is the treatment of choice. Usually we go for a 500 milligram drug. The drug which has got least chances of resistance is primarily ceftriaxone. That will be the answer over here. Of course, this question is not primarily based on whether you know that the treatment for Neisseria gonorrhea is ceftriaxone or not. Actually, I heard that based on the recalls, this question was primarily based on a case-based scenario. So this question is one-liner or this question's objective was primarily that whether you could diagnose the patient that the patient is suffering from gonorrhea or not. So of course, the answer for the question is going to be ceftriaxone because all of the other drugs cannot be used in these cases. We'll move to the next question, guys. Which of the following are the adverse effects of topical corticosteroids? See, we are not talking about systemic corticosteroids. That is a different set of adverse effects, which might include bone, or immune system related adverse effects. Here they have asked about topical corticosteroids. Of course, here we can see atrophy. Any steroid creams on long-term use, there might be atrophy, there might be hypertrichosis, there might be acneiform lesions in the patient, but blue-gray discoloration of skin will not be seen. Patients might develop purpura, but if in case purpura was given, that also would have been their adoption. But based on the recalls which we got, there was only blue-gray discoloration or bluish discoloration of skin, which is not actually seen with topical usages of steroids. So here, if the question is which of the following can be seen, the answer would be B, C, and D. And if the question is which of the following is not seen, then the answer would be A. As simple as that. We'll move on to the next question, guys. Which of the following is not true regarding bempedoic acid? First of all, we have discussed that all these questions, very much happy to say that all of the questions has been covered up in our sessions itself. So actually, based on the recalls, based on the points which we got, was all the topics were easy topics. The questions were easy topics, expected topics, but a lot of silly mistakes might be happening because there are lots of confusing options given over there. First of all, bempedoic acid is, we all know that this is primarily based from biochemistry, guys. Citrates from which acetyl-CoA is getting synthesized. And from acetyl-CoA, we have HMG-CoA. And from HMG-CoA, we have mevalonate. And from mevalonate, cholesterol is getting synthesized. This is the whole sequence of how cholesterol is getting synthesized inside the liver. This step is catalyzed by HMG-CoA reductase enzyme, HMG-CoA coenzyme A reductase enzyme, whereas the first step is catalyzed by the enzyme ATP citrate lyase enzymes. ATP citrate lyase enzymes. Well, that is getting inhibited by bempedoic acid. So simply what it does, it tends to inhibit the ATP citrate lyase enzyme, thereby it will prevent the de novo synthesis of cholesterol inside the liver. So how the liver will take up the cholesterol? It will start expressing out all the LDL receptors from the surface, takes out all the LDL cholesterol from the blood, thereby it will decrease the blood LDL cholesterol. Because if the synthesis of cholesterol is getting outsmarted, the liver will depend on the blood for the proper supply of the LDL cholesterol molecules. That's the reason why option D is a true statement. This is a true statement. This you can easily understand. It inhibits de novo synthesis of liver cholesterol. It is used, option C also is a true statement, guys. It is used when statins and diet cannot control dyslipidemia. I would be so happy if they have given high dose or high intensity statin therapy. So patients who are not even responding to high intensity statin therapy, they can be added up with bempedoic acid. But usually this bempedoic acid is been added with ezetimibe. That is a famous combination which we have. Usually this is the combination which we use in practice, but of course bempedoic acid can be added as an additive agent along with statins, or if a patient is not responding to statins well also. Now the option comes into whether option B or option A or option B. Of course, option A, no one knows the answer. Even I don't know whether it is dicarboxylic acid or oxalic acid. No one knows, because chemistry is very much far away from our knowledge. Option B, it non-competitively inhibits ATP citrate lyase. This we can clearly say that it's a false statement, because as we have discussed here, this is a competitive inhibitor of ATP citrate lyase. Because usually non-competitive inhibitors will not be utilized, especially which is pertaining to the basic physiological concepts, like beta receptors are there, which is there in the heart. Beta blockers are all competitive blockers. Even HMG-CoA reductase enzymes, inhibitors are competitive inhibitors. So all these inhibitors are primarily competitive inhibitors, but even option A is actually a true statement. It is a dicarboxylic acid. This structure is a dicarboxylic acid structure. So here, if the question comes, which of the following is true? A, C, D would be true. B will be the false statement, because it is not a non-competitive, it's a competitive inhibitor. We'll move to the next question. Carbamazepine and erythromycin was given to a patient, and he presented with ataxia and dizziness. Which of the following is the reason for the symptoms? Okay. See, first of all, carbamazepine, everyone knows that a famous concept. Carbamazepine is a microsomal enzyme inducer, whereas erythromycin is a microsomal enzyme inhibitor. Carbamazepine is an inducer, erythromycin is an inhibitor. Now the patient develops ataxia and dizziness. What exactly would be the reason behind? That's what the question is. Toxicity of erythromycin, toxicity of carbamazepine. Erythromycin speeds up carbamazepine metabolism, causes recurrent seizure episodes. First of all, this question's objective is based on when you administer a microsomal enzyme inducer and an inhibitor together, what will happen to the patient? Well, that's what the objective of the question is. Please note, induction means the synthesis of the enzymes is getting induced. So it will take a lot of time to see the responses of those inducers actually being there in the patient. But inhibitors, the enzymes are there. The drug which you administer will go and bind with the enzymes and tend to inhibit it, which can be seen immediately as early as possible. So when you administer an inducer and an inhibitor together, the inhibitor's activity will be seen at first. After like 2 months or after like 3 months of time, the induction activity can be seen if you administer too much amount of inducers for the patient. So here, as we can see, even if you administer carbamazepine along with erythromycin, the erythromycin's actions would be more. The microsomal enzymes would be inhibited. Thereby, carbamazepine's metabolism also is going to get inhibited. Because we all know carbamazepine is also called as an auto-inducer agent. What is an auto-inducer? It is metabolized by microsomal enzymes. It also induces microsomal enzymes, thereby inducing its own metabolism. So here what happens, one point which we can know is carbamazepine is a microsomal enzyme, is metabolized by microsomal enzymes. Erythromycin inhibits it, carbamazepine accumulates, causing toxicity of carbamazepine. Toxicity of erythromycin cannot be seen because we know it's practically not possible. Erythromycin speeds up carbamazepine metabolism. No, erythromycin tend to inhibit the carbamazepine metabolism. Causes recurrent seizure episodes. No, carbamazepine will tend to accumulate. How can we say carbamazepines? How can we see the seizure episodes to be increased? Actually, to say seizure episodes will tend to decrease. More pharmacological activity of carbamazepine will be seen in the patient. So that's why the answer for this question would be option B. We'll move on to the next question, guys. A patient was administered imipramine and was also given diphenhydramine. What can be expected in this patient? This is just like a direct one-liner based question, guys. Imipramine is a tricyclic antidepressant. It is an antidepressant agent. Diphenhydramine is an antihistaminic agent with anticholinergic properties. Diphenhydramine is an antihistaminic agent with anticholinergic properties. Now, one point, of course, we all know that tricyclic antidepressants tend to have three important adverse effects, primarily based from our sessions itself. Tricyclic antidepressant has got three important set of adverse effects. First one is it has got alpha blockade, muscarinic blockade, and histaminergic blockade property. All of these three will be seen with imipramine, which means tricyclic antidepressants. Diphenhydramine has got antihistaminic and anticholinergic properties. So when you give both of these drugs together, we can see more of antihistaminic property and more of anticholinergic property. Now, which option is given in the question here? Diphenhydramine inhibits the action of imipramine. No, both tend to enhance the action of imipramine. Imipramine reduces diphenhydramine's elimination. It has got no relationship with elimination. Both has anti-muscarinic actions. This appears like the right option. Both inhibits norepinephrine reuptake. Imipramine will inhibit norepinephrine reuptake because it is a tricyclic antidepressant, which inhibits norepinephrine reuptake and also inhibits serotonin reuptake. Well, those kind of responses are not seen with the diphenhydramine. So the answer for this question is option C. Both has anticholinergic or anti-muscarinic properties. Let's talk about the next question. Which of the following is a clinical cure for malaria? Which of the following is being used as a clinical cure for malaria? Clinical cure, again, we have, I hope you remember that flow chart, the drugs which can be used for the clinical cure for complicated and also for uncomplicated malaria. First of all, sulfadoxine pyrimethamine can be used in that conditions because if they have given Plasmodium vivax, in the question, sulfadoxine pyrimethamine cannot be included in that because we know sulfadoxine pyrimethamine combination is not going to be useful against Plasmodium vivax. But they have just asked a clinical cure for malaria, so this can be used for that. Artesunate, yes, can be used. Usually it is not given as monotherapy, it has to be given in combination, but it can be effective. It is not given as monotherapy primarily because it has got a shorter duration and to prevent emergence of resistance. Chloroquine can be used if the patient is suffering from a chloroquine sensitive malaria. Good. Primaquine has got no role with the clinical cure. Primaquine is primarily used for a radical cure. It is not used for clinical cure. It's primarily used for radical cure and also for your hypnoticidal property and the gametocidal property. So these are the different uses for which we can use primaquine. We don't use that for clinical cure. So the answer for the question would be B, C, D if they have asked about clinical cure. If they have asked which of the following is not used, then the answer is going to be option A. Good. Which of the following statements is true regarding benzodiazepines and barbiturates? Okay. First option, both act on GABA A. Yes, this is a true statement, guys. Benzodiazepine tend to have a GABA facilitatory activity, whereas barbiturates tend to have GABA facilitatory and a GABA mimetic property. With alcohol, it causes CNS depression. This is a true statement because both benzodiazepines and barbiturates should not be administered with alcohol because both are powerful CNS depressant agents. Flumazenil can be used for severe alcohol withdrawal symptoms. This is a false statement, guys. We cannot use flumazenil for alcohol withdrawal. Flumazenil is actually an antidote for benzodiazepines overdose. It is not been used for alcohol withdrawal symptoms. Actually, for alcohol withdrawal, we used to administer a long-acting benzodiazepine. We don't give a flumazenil, which might further worsen the symptoms. Both can be used as a sedative hypnotic. This is a true statement. I'm having a doubt whether this option was there in the question or not. But anyhow, the answer for the question, if the question is regarding true, it's going to be A, B, and D. C is going to be a false statement in that. We'll move on to the next question. Loading dose of an oral drug depends on which of the following? Of course, we all know that formula, guys, primarily based on the formula. The loading dose is equal to volume of distribution into initial plasma concentration. If the drug is given via per oral route, we have to divide the whole value by bioavailability, capital F, which stands for bioavailability. This is the whole formula for that. So here loading dose is dependent on volume of distribution. Yes, option A is there. Initial plasma concentration or simply plasma concentration, yes. Bioavailability, yes, bioavailability. It has got no role. Half-life has got no role with loading dose because half-life is primarily based on the elimination concepts. Loading dose is primarily based on absorption and distribution area. So here there is no involvement of half-life. That's why option A, B, and D would be the answer in this question. Again, all the questions are taken up primarily from the points which we have discussed already. Which of the following psychoactive substance has antidepressant properties? Okay. See, bupropion, yes, it has got certain antidepressant properties, but it is not a psychoactive substance. First point is getting cancelled. Cannabidiol, yes, it is a psychoactive substance, but it has got no antidepressant property. Ketamine, we have discussed that already, my dears. If a patient, you remember that, if a patient is not responding properly, if a patient is having addictive activity, when the patient is getting admitted in the ward, we can administer ketamine as an infusion, a commonly used drug for management of acute episodes of depression. Ketamine is also a psychoactive agent, and that's why ketamine would be the answer in this question. Mephedrone is actually a psychoactive substance, but it has not been primarily used as an antidepressant agent, guys. The answer for this question is option C. Ketamine is the answer. Let's move to the next question. Match the following: schedule and drug. Schedule H, Schedule G, Schedule Z, and Schedule X. Insulin, morphine, veterinary drugs, and hepatitis B vaccine. Don't worry, even I don't know what exactly stands for veterinary drugs, right? Because that's totally out of our own phenomena. The drugs, and this is primarily based on Drugs and Cosmetic Acts. Drugs and Cosmetics Act, which was passed in 1940. Based on that, they have asked this question. First of all, one thing which we know, I hope you remember that mnemonic X is for psycho. That's any psychotropic agent, any addictive substances. Here X would be, we know it's going to be morphine. Schedule Z or Schedule Z is for veterinary drugs. Now we are having a confusion. No? Schedule H goes for insulin or hepatitis B. Schedule G goes for insulin or hepatitis B. We're having a confusion in it. I'll take a picture of that schedule, drugs and cosmetics, and I'll just explain that to you itself. This is a picture which is taken up from Drugs and Cosmetic Rules 1945. We have Schedule H. Within Schedule H, as we can see over here, hepatitis B vaccine is there, which is included in the Schedule H, which means Schedule H is for hepatitis B vaccine. Similarly, we have Schedule G. G is for Schedule H, mostly we will be knowing it, administered only Schedule H means sold only with a prescription, guys. Schedule G, remember, guided by a doctor. G is for guided by a doctor. I hope you remember that mnemonic. Schedule G is for, it must be administered only under an supervision by a medico. Here they have, under Schedule G, we have insulin. All types of insulin will come under Schedule G. So the answer for this question, Schedule H is for hepatitis B vaccine. Schedule G is for insulin. Is that good? Moving on to the next question, guys. What is the mechanism of action of phenol-dopam drug? Phenol-dopam, again, I hope you remember that three important drugs are there. Phenol-dopam, we have phenol-dopam, dobutamine, and dopexamine. three drugs which tend to have a name which is very much similar to dopamine, but it has got certain other activities. We had discussed all these three drugs in the same format. Dobutamine is more of a beta 1 receptor agonist agent and a minimal beta 2 receptor agonistic property. It has got no dopaminergic agonistic property. Dopexamine is a D1 receptor agonist and along with a beta 2 receptor agonistic property. Whereas phenoldopam is a D1 receptor agonist and alpha 2 receptor agonist agent. That's the reason why phenoldopam can be used for hypertensive emergencies, because by stimulation of D1 receptors, it will dilate the renal blood vessels. By stimulation of alpha-2 receptors, it will inhibit the release of noradrenaline. Thereby, it will produce systemic vasodilatation. That's why phenoldopam has been approved for hypertensive emergencies too. And that's why the answer for the question, the best answer is going to be D1 receptor agonist agent. I heard there were a longer option in that, but don't worry, the answer is D1 agonist. It has got no alpha 1 agonist, beta 2 agonist, D2 agonist, antagonist. All these actions will not be the answer for this question. Moving on to the next question, guys. Which of the following anti-epileptics is not given during pregnancy? Not given during pregnancy. Of course, we know valproate is not being given because of spina bifida. Usually, it is not been preferred. Lamotrigine is preferred. Levetiracetam is preferred, and carbamazepine is also not preferred during pregnancy, especially in the first trimester of pregnancy. So, if the question is which of the following drug is the safest to be given in pregnancy? If a question comes, which of the following anti-epileptic is the safest to be given during pregnancy, none of the drugs will be the answer there, because none of the anti-epileptics is safest in pregnancy. We have to go through the adverse effects. Based on the incidence, we can opt for lamotrigine or levetiracetam. Valproate and carbamazepine are not been administered in those cases. Well, that's the answer for this question, guys. Well, these are the questions which has been asked in this current pharma INCT May 2025 pharma questions. I hope I have covered up most of the pharma related questions, very much clear cut. And if in case any other questions has been left out, and please put it up in the chat box, and we'll be having a complete discussion of all the questions put up together, and a detailed discussion will be read up in our doc tutorials app in the QBank section, and also under the previous year questions recall sections, guys. So all the best, and I hope you'll be having